Welcome everybody, and I'm here with Mr. Ben Cormack from Core-Kinetic. Hi Ben.
Hello Anna, how are you?
Very well indeed.
That was very formal, that was. I'm not used to it. I'm not used to this formality.
I know, so it was, yeah, but that's where the formality started and stopped. Now we can go back to one normal chip chat.
Yes.
This is Ben Cormack, him and his full Cockney accent. Ben is gonna present a course here at the school down in Exeter on lower back pain, evidence surrounding lower back pain and movement. We're so looking forward to this course. We ran it a few months ago. We used to run it years ago when the original course started, which I think it was around probably 10 years ago or so. No,
2013, I think it was.
2013, you're correct, 9 years ago. So this course has evolved. I have to say, your course was part of it helped me understand new evidence. It was part of my moving and learning more about evidence-based practice. And so thank you very much, being influential of that, in that. But Ben, why did you create the course originally? And what is in the course and how it has evolved?
I think for me, the point of the course is to bring together lots of different subjects that relate to rehab. So we have courses that are about back pain. We have courses that are about exercise. We have courses that are about pain. But sometimes what we don't have is a way of bringing these things together. So for me, you know, I want to be able to say, well, how does movement and exercise relate to pain? How does pain relate to back pain pathology? How does that relate to person-centered care? What's the evidence that relates to that? So rather than going on 100 different courses about 100 different things that you have to connect the dots, you know, what I'm trying to do is connect the dots between all of these things. And this is exactly what happens in clinic when we work with people. We have to connect the dots and be able to communicate. We have to connect the dots in terms of the evidence. We have to connect the dots in terms of assessment. We have to connect the dots in how we get people moving from a psychological and a physical perspective. So it's about bringing all of those things together. And that's exactly why rehabilitation for pain and exercise and movement for pain are just not the same as they are for fitness. The rules change when you have people in pain with painful problems, with a mindset that is pain related and having problems in their lives. This changes the game from a healthy person lifting weights in a gym. It's a totally different proposition. Anyone who's worked with people knows that. And the course is really about connecting the dots.
Yeah, and you know what, having done your course from the beginning, from the one original and the most recent one, this is one of the feedback we get from the students, but this is also the feedback that I will give myself. Is so clinically relevant for the type of people we as massage therapists, soft tissue therapists, sports therapists sees most of the clinic. We see the John the gardener with lower back pain. We see, you know, Francis that likes to go walking with her friends, so that might struggle with their knee. So those are the people, and people that they might not have access, or the gym environment is not what they want to, but they need. And what I also found on your course is just you give you give strategies. So you have this part of theoretical part and going through the evidence with your massive brain. I mean, I'm so jealous of your brain, not of your accent, but of your brain, certainly. And then you just, like that, you got this ability to translate it for us in practice. It's lovely, actually. Well, that's a compliment, Ben. Well, that was my question. That was a compliment.
Well, I appreciate that. And I think one of the problems that we have sometimes with evidence-based medicine and lots of theory that we have is sometimes it's quite difficult to interpret it and also then to be able to put it into practice. And we need to know when sometimes something is so academic that it's interesting to know, but actually could be not that helpful clinically. And, you know, it doesn't mean that we shouldn't know it, but we also need to know what's usable from it as well. So I'm a real big, you know, advocate of using evidence-based medicine to help people clinically, not just academically.
Yeah, I think that's important, because this is, again, is another feedback that people do. We tend to get, you know, they do these amazing courses, online courses, all this great knowledge, but actually then what does it look like in clinic? What does it look like on Monday morning in clinic? And this is important. You know, you wrote a fabulous paper with Peter Stilwell and, sorry, her name keeps
Sabrina Connix.
Yes, absolutely fantastic.
And Joe Gibson as well, yeah.
Oh, yes, of course. I'm a big fan of Joe. And I love how you guys brought the BPS and actually how we might have misinterpreted in clinical practice. And then we kind of complain that the BPS model is, we need to move away from the BPS model, but actually we never applied it. And this comes very much into your courses. Is part, he underpins all of your courses. So it's beautiful, because like you say, you know, you don't want people to go to courses to learn all these things. Actually, a course is a beautiful integration of all of it.
But I think this is the point of having a strong clinical philosophy, that if you have a strong clinical philosophy that has, you know, strong elements that you believe in and you care about, then those things should be woven into everything that you do. And I think there's a really nice quote from my friend Sandy Hilton talking about pain science. It's not a modality to be used, it's the air to be breathed. And I think, and I think that's the point of the BPS model. It's not just a way of finding more things to treat. It's actually
not an intervention. It's
not an intervention. It's a philosophy and a way of working. And that might incorporate intervention and it might incorporate assessment, but it does it with an underpinning of humanism and caring, which actually, if you think about the BPS model that relates to pain drivers or causation, well, how the hell are you going to get there to get people to trust you and talk to you if you don't underpin that with a philosophy of care? And so I think that one cannot exist without the other. And sometimes we've taken the BPS model and viewed it very much through a biomedical lens. It's another way to intervene. It's another way to treat. But actually, without the care part, it probably is fairly redundant. Yes, exactly. There you go. So I call it the two sides of the same coin. And, you know, it's a wonderful coin and it's got two sides. But sometimes, you know, people maybe focus on too much on one side or the other. And actually, we need to have the caring and the, you know, the skills to communicate to be able to get us to the more diagnostic treatment part that seems to be quite popular.
Ben, what do you think if you would have to say to people why you chosen? I love always the reasons why you chosen to particularly focus on the lower back part of it, because originally it used to be therapeutic movement. The course used to be therapeutic movement. It was brilliant, absolutely. But now you put another dimension. You're focusing a little bit more onto lower back pain. Why specifically lower back pain? That's really interesting.
But, you know, and this kind of goes back to kind of what we're talking about. I think lower back pain is one of the most misunderstood conditions. I think we just go, oh, it's lower back pain. And, you know, actually non-specific lower back pain is quite a complex entity in the sense of it's hard to define exactly what it is. You know, you're working with factors that relate multidimensionally across the BPS spectrum, whatever that is. So for me, I think with this underpinning of you know, maybe from my interest in the BPS model, lower back pain is probably the most BPS condition that we have, I think. Not to say that all conditions aren't biopsychosocial, you know, but nothing escapes.
Like the driver, yes.
But I think, you know, that when it comes to, you know, I think lots of other conditions, we guided more by pathology. And actually with lower back pain, especially non-specific lower back pain, for want of a better terminology, we have to be guided much more by people. We don't have the same pathological or the same knowledge of assessment or these type of things that we look. How many special tests are there for the back? Not many, right? You know, if you consider how many special tests are there for the shoulder, like 11 billion and one. And I think that, you know, the lower back is definitely somewhere that we've investigated a lot, but we don't have a lot of answers. And because of that, being guided by the patient, I think, is probably the best way forward to work with that. And I think that fits in very much into my BPS philosophy. So did it choose me, Anna? I don't know.
You did oh, that is so
did I choose it or did it choose
oh my
me?
God. This is such a big Cormack.
Yeah, no, I don't know. I think it's just an area of interest, and I think it's acceptable to be quite biopsychosocial in this context. So maybe it's actually about, you know, it's acceptable to be me in the lower back space. I don't know.
But also because personally, I find that lower back, there is so much about lower back research out there, and so many good studies, others which are not very good studies, some very kind of guidelines, very different guidelines from each other. And so I think it's quite good to have everything brought together, because we, in a sense, Ben, although we should be always critical critical of every lecturer, instructors, we trust your understanding or research. We trust the fact that actually you might have your biases, but actually you keep them under control. So you're quite an objective. So what the research that you screen through, it's valid, it's solid. And this is why we always recommend to our students to go through your fabulous website, 𝐸 and be part of your membership group, the BCP, because you guys are good. Well, you can be trusted. You can be trusted. That's
and it's not that we don't have our biases.
Oh yes, I know you have.
Yeah, it's about being open and honest about your biases, being critical of your biases, and just presenting information from a broad spectrum of different sources and different people. And you know, I think that's really important, to try and be as, you know, to some degree as transparent as possible. And in lower back pain, you know, even though we have all this research, sometimes it's actually, we have lots and lots of research. We have too much research, actually, but we don't always have a great deal of guidance from that.
No, indeed. So for anybody who wants to attend Ben's course in Exeter on the 3rd or 4th of December, we're going to leave a link in the comments, and looking forward to see you then. Bye now.